This episode is brought to you by Mott's Applesauce. So you're looking for a snack your kid will love and you can feel great about? Give them a Mott's no sugar added applesauce pouch. Made from real, delicious apples and a good source of vitamin C, too. Perfect for tossing in a lunchbox or grabbing for on the go. Mott's. Real apples make real good applesauce. Learn more about Mott's no sugar added applesauce at Motts.com.
You set the table, put on a playlist, even made the lasagna from scratch. And now you're wearing it. OxiClean Max Force Spray tackles tough, set-in stains the first time. Adulting is hard. Fighting stains shouldn't be. OxiClean Max Force. It's not clean unless it's OxiClean.
Atheists, agnostics, long-haired weirdos, short-haired weirdos, vandals, hooligans.
The government, hug the government, love the government, hug the government, love the government.
Welcome to The Politics Guys, a place for bipartisan, rational, and civil debate on American politics and policy. I'm Trey Orndorff, a political scientist at Oklahoma Christian University, and today I'm joined by a really amazing guest and author, Dr. Tyler Evans. He is an experienced and passionate infectious disease and public health expert who has been on the front lines of major disease outbreaks around the globe, and not just here in the United States, but elsewhere, including in Africa, South Asia, and the Middle East, and included working with many organizations such as Doctors Without Borders and Partners in Health. And today on The Politics Guys, we're going to be discussing his book, Pandemics, Poverty, and Politics, Decoding the Social and Political Drivers of Pandemics from Plagues to COVID-19. And it has just come out this month, that is August. And Tyler, I have to say that your book wasn't just well written, but for me personally, it was actually at a perfect time because as I was reading it here at the beginning or the end of the summer, rather, I am actually leading conversations here at OC about our own healthcare systems as our faculty association president. And so it all came together for this and for the show. So I'm really excited. So welcome to The Politics Guys.
That's great. I really appreciate that. And, you know, as it's new, I think you're probably reader number, or as far as I know, reader number 5 that's completed it. So
okay, I love
I appreciate
that.
the fresh perspective.
Well, thank you, Tyler. Well, why don't you? Obviously, I've had the chance to actually, dive in and read your books. That's one of the things that we always do here in The Politics Guys is we actually read. I've got notes here. We're gonna go through. We're gonna chat. But obviously, not everybody who's listening right now is gonna know. So I always love to start by asking our authors, sum up your book in that 30 to 1 minute kind of version for listeners, so that we could have a starting place. What drove you to write it, and summate it for us, please.
Sure. So the genesis of the book really, it was written over the course of 20 years in my mind, and a lot of sort of narrative and whatnot from the sort of the field. My career was not in an ivory tower. I was in the foxholes of the inequities, both in the global South. We define those as low and middle income countries, war zones, complex humanitarian emergencies. Was on the front lines of the Ebola response twice. And then, I've been in a number of leadership positions too. So I understand both the macro and the micro. And in the height of the pandemic, that really was, for me, that was the precipitating element to really let's get this done. I got to get this out. Because no matter how many resources that I had, I was the chief medical officer for New York City. We had FEMA dollars, we had all these city dollars, and all of these, we had these, high-rise hotels and all of this stuff. And yet we couldn't engage a lot of folks and keep them safe. Why? It was because of distrust. And so ultimately a lot of my work, both in sub-Saharan Africa or the global South, as well as is in the US, I found that while the sort of the magnitude of the burden of disease is considerably different, the sort of the drivers are very much the same, right? The determinants are socially and politically the same drivers. And so that's why I sort of finished the book. And then I could, in 30 seconds, I could summarize the 3 different sections.
Yeah, please. Give us that kind of overview for the book itself too.
Yeah, so the book is basically, I mean, the intent of the book is it's a crossover. It's intended for a crossover audience. So it's not intended for healthcare professionals. I mean, healthcare professionals are welcome to read it, but I know for a lot of them, I'm sort of preaching to the choir. But it's intended to be a crossover book. It's intended to really be as digestible and accessible as possible, right? By definition, because that's what sort of equitable sort of approaches are. So we want this book to really be well understood. We don't need all the fancy medical jargon and whatnot. Even break it down in like a sort of in the appendix. I break it down all the definitions into a chart, and I kind of like channel my Malcolm Gladwell, and sort of writing this book just to make it again just as easily understandable as possible, so people can really make a difference. So we have that sort of light bulb moment, and hopefully some sort of decision makers and sort of impact makers and whatnot could ultimately sort of change things in the future, hopefully policy. But yeah, anyways, it's broken up into three different sections. The first section is essentially the social medicine, the social determinants of health. It's well described. What is it though? In the simplest possible language. The second section is how does that sort of apply to infectious disease outbreaks or pandemics? And so what I do is I start with the third plague, 1899, and then I end with COVID-19, and with that, and four different flu pandemics in there as well. And I define pandemics in a particular way, and so I demonstrate the social and political drivers of each of those, and I even provide a rubric, for the reader to basically kind of sort of grade them themselves, and hopefully it's that sort of realization tool that ultimately when they get to the end, they're like, okay, and then the third section is okay. Now that I hopefully have your attention, what are we going to do about it? And so I give some sort of recommendations, which are very timely in our current space.
Yeah, and we'll get to some of that timely stuff in a minute, but I really want to start with the book itself because it's so important. As a matter of fact, what I really want to start was, like you had mentioned it a second ago, you have this section early in the book where you're talking about, look, you were there in New York, and you had locations. You talk about, you have the hotels, the places, so that you can isolate individuals who are being infected. But the problem ends up being not the 800 some million that the city of New York is spending. I think when I added it all up, what you were talking about there, the problem is that there is this fundamental level of distrust and polarization about the very fact that you guys were giving vaccines, and this was not new overall, right? You make the point that this is something that you've experienced in other locations, but generally speaking, that has not been true in the United States. And so it was a little bit, the magnitude of that difference seemed a little bit different, and that hit me hard personally because I recall, I work here at Oklahoma Christian University, and I'll recall the amount of pushback when we said, hey, if you want to come back in person eventually, you've got to have the vaccine, and the number of families who went, I don't know about that, right? But generally speaking, as you point out in the book, that's what we would expect to be problematic in terms of economic status. But this kind of comes across the board. So talk us a little bit through those political factors, those socio-political factors you talk about in that first section, and how really disinformation and political targeting has led to worse outcomes in your view. And again, that's a big part of what you talk about there in that first section.
Yeah, totally. Thanks for that. That is, that's a key component of the book. I mean, that really, there's a common thread throughout all that. And there's a section that I write about, which is called population stress. And so for me to just sort of try to break this down in the simplest possible way, when we talk about stress from an immunological standpoint, we are we can sort of describe that as either physical or emotional stress, right? And so the physical stress could be infectious, could be some other component, but could just be emotional. I'm literally stressed, right? Or I've not slept well, et cetera, et cetera. any of those will ultimately break down one's sort of immune system. And, I often talk about homelessness. I work right now with Wellness Equity Alliance, my organization. We focus a lot on street medicine, so providing direct clinical services to the unsheltered, unhoused. And at one point, when we had all the different sort of priority populations, when the COVID vaccines were getting rolled out with ACIP and all that, they didn't include people experiencing homelessness as a sort of risk factor. They would say anybody with sort of, immunocompromised individuals, et cetera, et cetera. So I made the argument, because I was at Alameda County at the time. I made the argument that we should just treat all people experiencing homelessness, particularly the unsheltered, as immunocompromised, right? Because they're rough sleepers, right? There are so many other stressors that are sort of taking place in their lives, and so by definition they're food insecurities, et cetera. So they're immunocompromised. But getting back to population stress, essentially, when the body's immune system is stressed, there is going to be that compromised sort of element. And so as a result, other opportunistic infections can sort of come in very easily. So that brick wall that we typically have up is depleted, right? That army is depleted and the invaders can sort of come in. So if you zoom out, right? And and one important sort of other metaphor here is herpes simplex 1. Almost everybody has it. Over about 80% of humans have it. They like to say that they don't. They'll get a cold blister. They'll just call it a cold sore. I'm like, nope, it's herpes.
It's herpes.
But,
yeah. I have it, just to be clear. Yeah.
And so you will get that, when folks are stressed, right? Again, when they have a cold, again, when they're not getting sleep or something like that, you'll get that cold sore, right? It's a perfect example of what happens on a macro level, right? When you have a population that doesn't trust each other, where there are mass polarizations, where there's a lot of inequities, when there's infighting, particularly when there's infighting, civil war, et cetera. And I make examples to, HIV arising in South Africa in the 80s and the 90s, as well as Ebola in Sierra Leone, and obviously with COVID-19 in the United States. That population stress is when those systems do not trust each other. And then, so there's already, that population is immunocompromised, right? The metaphor is they're immunocompromised. They don't have that sort of that brick wall or that army to sort of, to protect themselves. They don't have that public health infrastructure in place to protect themselves from invaders. And so when you throw in a dangerous infectious disease outbreak and they cannot cope, they cannot respond quickly. And as the result, something that could have been easily controlled, possibly even prevented and certainly mitigated, ultimately does not happen. And so as a result, it turns into an epidemic and then a pandemic. And until we address that core element, and right now we're going backwards, right? But until we address that core element, we are not going to be able, we're going to continue to see these pandemics and they're going to continue to get worse.
Yeah, and I love that you started with chatting about in terms of the unhoused, right? That is something my sister-in-law works for the healthcare. As a matter of fact, she's a discharge nurse is what she does. And one of the things that you point out in the book is kind of this misconception, because you go through, there's these different kinds of ways that we can set up healthcare systems to try to combat health, right? And to keep health. And you go through the major versions of it. And in the kind of market system, you make this really excellent point where you say, look, it's not that the individuals on the poor side of the spectrum are not going to have any healthcare, but they're going to access it in suboptimal ways. And because of the ways that they're accessing it, it can actually also increase the cost, right? So for example, the person who is unhoused, they're going to end up in the emergency room as opposed to primarily going through, say, having a PCP, or maybe there's not even access to a PCP they can get to. Another piece of your argument is things like we don't think about the fact that early vaccinations often deal with transportation, right? So I was able to get vaccinated. So I'm immunocompromised, but I had a car, so I could actually go down. We were doing it at the Science Center. That's a ways away, but I can do that. I don't need a bus to get me to the Science Museum to get that first dose. That was a really big deal. Talk to us through a little bit of how, because that's a big part of your book, the choices for how we arrange access not dictate, but influence those healthcare outcomes?
Right. So what I'm hearing, the question is largely just sort of unpacking more of the social determinants and how that particularly connects to protection or population prevention, particularly for infectious
Yes, because
disease.
I don't think most people, when they think of healthcare, they're not thinking about it in those terms. So give us some more of that, because again, that is something I want students to read about and think about. We just don't think about that as a country, right? That your car, the access to it in itself is part of that healthcare package.
So when we first were, so I was the incident commander for mass immunizations in the Bay Area, and I was and also the deputy public health officer for Marin County. When we ended up, New York Times described our vaccination efforts as kind of one of the best in the country. There's a lot of reasons for that, but as we were standing these up, and then I ran this company called Curative, where we ended up administering over 2 million COVID vaccines across the country, with over 1 million in California. We were running one of the biggest, we called them pods or points of dispensing, mass vaccine clinics. I'm sure most people saw some form of that during the height of the pandemic, and so one was at Dodger Stadium. We were doing upwards of 14,000 shots a day. And, in the very beginning, Trey, what we were seeing were folks that were looking very much, looking very similar to one another, right? There was a clear pattern, and we used to jokingly describe them. I think I write about this in my book, but we used to jokingly describe them as the triple C's, or Caucasians
Yes, you do
with cars.
early. Yes. Continue. So sorry.
So Caucasians with cars and computers, right? And so that to us really just described, how access to healthcare in the United States is set up for the most part. Yes, is simplifying it, but that's kind of the point, right? So yes, literacy, digital literacy is a big component, right? So folks that, because almost all of those appointments in the very beginning, you needed to have a computer, B, you needed to have internet, bandwidth, or connectivity in order to sort of access it. Third, you needed to have that literacy, right, to actually understand computers. Now, the reality is in the United States, our literacy level, forget health literacy, our literacy level is 5th grade. Okay. 5th grade. And that is in a country which we are still, the wealthiest country in the world. I mean, I don't know how long that's going to be, but yeah. So with that, that 5th grade, so you have mass wealth, in a country like ours, but you still have this considerable sort of literacy or illiteracy sort of issue. And then you apply that to health and it gets even worse. And then you apply that to the digital space, it gets even worse. So that becomes that polarizes those access sort of, components. That's one, right? The health literacy is another, right? The understanding what's the point? Why are vaccines important? Et cetera, et cetera. Now that got weird, right? And we can talk about that. And it wasn't just folks that didn't have the health literacy. It was folks who were perhaps too health literate or didn't have the right health literacy. That's what a lot we were seeing in, like, for example, in Marin County, where the average educational level was pretty much like PhD. It actually was like master's level. So there, and then of course, race is a driver, right? I know this is a divisive element. I know a lot of folks disagree with this, but this is evidence-based, right? This is an absolute fact. And when it came to the beginning for COVID-19, when we were describing risk factors for both infection and for adverse sequela, it was people of color, especially African Americans, right? And it wasn't because of some biological element, but it was all of the social elements that connect. And most of that is trust, right? And so when we have things like, the Tuskegee experiment that happened where we were forcing African Americans to basically, to get syphilis and to basically keep the syphilis so that we could, without treating it, even though we had a treatment, so that we could watch the natural sort of progression of disease, that is what is often referenced. And so when you have low vaccine uptakes, I mean, when it came to the height of the pandemic, the two groups with the highest or with the lowest vaccine uptake and the highest levels of hesitancy or lack of confidence. There was a lot of different sort of references that we use there. It was African Americans and Republicans, and there could be both, but those were the two groups for different reasons, right? And trust of systems is a big one, and we've got to get that trust back, right? And what we're doing right now in the country is not doing that, right? We need to depoliticize public health. Public health is a common good. It's the most effective public health mechanisms should almost be invisible, right? People shouldn't even know that they exist. They are out there. They're creating those sort of those guardrails around communities, right? To ensure that communities can thrive, not just survive, but thrive, right? To ensure that infectious diseases that are coming out there, especially emerging communicable diseases that are coming out, are detected and responded to as quickly as they possibly can without ever, kind of impacting those populations, to ensure that they have the right access to food, so food security and of course, sort of vaccinations and health education and all these other elements to make that. And then there's health care, which is a little bit different. Public health and health care, not exactly the same thing, but they should be integrated, and as much as they possibly can be. And that's a big problem with the U.S. The way that the systems are set up, public health and clinical services are not well connected as a general rule. In some places, it's a little bit better than others, but particularly when we see more fractured elements of those systems, the more that we see disparities in those areas.
And so this kind of brings me to that was the one maybe question mark I had as I finished your book, but it comes up several times, and that is even the language you're using there. I agree with you. I do very deeply, and you argue specifically that we need to remove political interferences from public health services, and I actually shared that with a few trusted individuals who I know who come from a very different political persuasion than I do, and their immediate response was something along the lines of, "Oh, he's one of those." Right? It was all some variation of that. As a matter of fact, you get at that. In the introduction to your book, you even say, look, this book makes a case for a rational system that depolarizes our communal need to address the root causes of disease. And it outlines a roadmap for the future of infectious disease detection, prevention, and control. And it creates a call to action for all global citizens to do their part in addressing the social determinants of a future pandemic. And you on the one hand, you want to depoliticize, and I'm here going, yes, but at the same time, the language that you're using isn't of itself going to, by its nature, be polarizing. Not that it ought to be, right? So I'm not charging you with being, polarizing, but I don't know how to get away from handing that. Let's just be frank, handing that, as you pointed out a second ago, to some of my more fervent kind of MAGA Republicans, or even I think of one of our MAGA Republicans here on the show, and they're already going to go, "Oh, he's Fauci 3.0," right? How can we actually then get to a level where we're going to be depoliticizing some of those items when the very nature of the language of health systems can be triggering to such a large portion of the population and potentially even some of our listeners?
In the time it takes us to say, we're using Folgers instant coffee, seamlessly blended with water and ice. A splash of whatever kind of milk is your thing. And gotta get that caramel drizzle. All to make a toasty, roasty, caramel iced coffee. You could be enjoying it. Every damn sip of it. Damn right. It's Folgers Instant.
Eczema isn't always obvious, but it's real. And so is the relief from Ebglyss. After an initial dosing phase, about 4 in 10 people taking Ebglyss achieved itch relief and clear or almost clear skin at 16 weeks. And most of those people maintain skin that's still more clear at 1 year with monthly dosing.
Ebglyss, lebrikizumab LBKZ, a 250 milligram per 2 milliliter injection, is a prescription medicine used to treat adults and children 12 years of age and older who weigh at least 88 pounds or 40 kilograms with moderate to severe eczema, also called atopic dermatitis, that is not well controlled with prescription therapies used on the skin or topicals, or who cannot use topical therapies. Ebglyss can be used with or without topical corticosteroids. Don't use if you're allergic to Ebglyss. Allergic reactions can occur that can be severe. Eye problems can occur. Tell your doctor if you have new or worsening eye problems. You should not receive a live vaccine when treated with Ebglyss. Before starting Ebglyss, tell your doctor if you have a parasitic infection.
Searching for real relief? Ask your doctor about Ebglyss and visit ebglyss.lilly.com or call 1-800-LILY-RX or 1-800-545-5979.
Yeah, I love that question. And it's the irony of, when there is a statement saying, let's depoliticize this. It's essentially like saying, let's, if you're in a boxing match, let's make sure that we've got some rules, to it, and that that we have some parity and some justice. And justice is even a polarizing word.
Oh my goodness! Yes, okay. Yeah. I'm a little triggered here, but I'll let you know. I had attended church across the street here, and we were bringing up one of our new concepts, which is justice, part of our church. You might. I'm not sure. Had you dropped a hand grenade in the church service, I'm not sure if that would have been a more than just the term. Well, what do we mean? So continue. Sorry, I don't. Yeah.
So so I think when people hear that, they're like, oh, you're one of them, right? So that's what they hear. And so I think, Trey, the only way that we're going to get through that is through more conversations. We have to have more conversations. And the problem is this country has been so divided. And who thought public health, particularly vaccines, face masks, would be like, we know, guns, religion, abortion. These have been the core dividing elements of this country for as long as I've known. Who knew that it would be, vaccines and face masks would be the sort of this new frontier of divisiveness, and a big part of that, I can touch upon that for a second as to the why.
Yeah, please do, because that was interesting too. Yeah,
but the problem is we have, particularly since social media has emerged, we are stuck in our echo chambers and we're not having conversations. And so our perceptions, right, not based on evidence, our perceptions are further amplified or further polarized, and then they become weaponized, right? And so they can't hear. Folks cannot hear the other side. And sometimes it's hard for me to do it, I'll be honest, but I really force myself to listen to all possible kind of news outlets. Google News is typically my news source, right? Because I can toggle between, your Fox News or your Al Jazeera, and I appreciate that. I lived in the Middle East for years, and I would I would toggle back and forth between, Noam Chomsky and Alan Dershowitz, so that I could get a better understanding of one of the most complicated and protracted, conflicts that we've ever seen in our contemporary world. So we've got to cut through that crap and just talk, and the reality is different things matter to different people, and so I guess when I'm talking particularly about, the messages of public health and why investing in the social infrastructure, why the politics should not be sort of incorporated in that, why that matters is because ultimately it could be your moral philosophy, which is for certain people, which is a beautiful thing. If that's not there, and that's not there for a lot of people, and that's fine, then let's talk about how that's going to impact your concentric circles, right? How that's going to impact your communities, your local communities. When you need to get into a hospital and everything's gummed up because we didn't invest in that, okay. That's where we're at, right? When your wife or your uncle or whatnot, is having a heart attack and they cannot, their response is significantly delayed, and that person's sort of fate is determined as a result. These are real existential elements that will exist. And then there's your bottom line, right? The economics of it. It does not make economic sense to not invest into prevention for all folks. You might have your your positions or your policies or ideas about homelessness or refugees or migrants, et cetera. I know that those are provocative conversations, and I am not going to have those conversations with people who already have a very sort of strong sentiment about that. That is not my space. It's actually the same. It's the same thing when it comes to me as a doctor managing patients that are currently addicted to drugs or substances, right? I'm not going to preach to you about why drugs are bad, right? I'm not going to preach to you about good decisions or bad decisions, but I'm going to reduce harm, right? So there's a movement called harm reduction where we're reducing harm, right? So what we'll do is we'll give people clean needles and syringes, right? We are not, and that becomes political too, because they're like, oh, you're promoting drug use. I'm like, nope, not promoting it, right? I'm an infectious disease doctor. I've seen people die of AIDS. I don't want to see that in this community, right? That's it. I am reducing the risk of infectious disease, like full stop. So that's and it impacts the economics. You don't want your kids stepping on a needle and potentially being at risk for HIV. That costs money, and that impacts your moral currency as well. So you've got to listen to like where folks are at and try to connect to what's important to them. And those are the conversations that I was saying. To get to the other point as to sort of why I think public health became so politicized during particularly the pandemic, and as it is right now, is because we allowed it to be. We created a political divisive culture around it, and that should have never happened, right? Public health, the core bedrock of public health is science. Science drives public health. Public health is the manifestation of policies, implementation of policies as the result of evidence-based findings. And so we are going to, use that science, and science could be wrong, right? Everybody, Fauci was the very, polarized, even though he was the most, he went through, 5 presidencies, survived 5 presidencies. But they still wanted to hang him as the Judas or whatever of that administration. And but the reality was, Fauci said this and Fauci said that. Well, because science can be wrong. Science ultimately, that's the beauty of it. It is ongoing. It is constant. It is constantly being tested, and through that experimentation, it might potentially sort of become, we might determine that what we sort of previously thought was not correct, and we will accept that, right? That is the reality of our universe. So the problem was we used these sort of some of these erroneous findings or whatnot, and then we really just weaponized those as much as we possibly could, right? And we had on the federal level you had the president and the sort of chief scientist sort of not sort of connecting. You had different people spreading misinformation or even disinformation, which what we're seeing right now. And so what happens with that? Okay, so the easiest possible scenario I can explain is, let's say you're at the ER and you've got 2 doctors that are right in front of you, right, that are actively arguing about your diagnosis and your treatment. Is that going to give you confidence or security in the sort of the system or the sort of degree of treatment in that healthcare system or that hospital? No, you were going to say like, no, I do not I need a third, consultation or something like that, which is going to get even weirder. So we need to be on the same page. Okay. And that's what I was saying, that science again is not political, right? Public health again should not be political. These are facts. Facts are facts. And the folks have to listen. They have to listen to the professionals. They have to listen to the doctors. They have to listen to the nurses, the epidemiologists. Everybody became an armchair epidemiologist, during the
I loved that phrase in the book. I actually just laughed out loud. Continue.
Yeah. So I was the first chief medical officer for New York City. So I was literally I'm partly writing the policy, partly sort of implementing the policies. And, I'd go into restaurants, and New Yorkers have very strong opinions. That's why I love New Yorkers. But I'd come in and they're like, no, you have to do this and that because CDC says this. And I'm like, Okay, can we talk about this, right? Like I do have a fair amount of knowledge on this, and they're just so profoundly stuck in their opinions, and it's because again of that divisiveness. And people, the pendulum swung in this direction and that direction in certain states. It got so weird because people could not be on the same page because people were not in agreement, and that should not be the case. Again, you have the evidence, and that's it. So in a perfect system, basically, you have at the federal level. And that could, I mean, we have to decide on who that's going to be once the sort of country is normalized, if that ever happens. Then ultimately we need to identify 1 to 2 federal agencies that are essentially when we have a public health emergency. It's just like the same thing with war or a fire, right? You have an incident command, right? This is what we do all over the world, right? And it works well. Why it got weird with public health, again, getting back to that sort of that there's that misalignment. But basically you have emergency here, 1 to 2 federal agencies, essentially then having sort of like, a chain of command with states, counties, cities, and then having conversations with community-based organizations, community health workers, folks that have the faith and trust, of certain sort of communities, interfaith communities, communities that represent certain key interests, et cetera, et cetera. You've got to act that all has to be activated at the same time. So everybody is basically reading from the same sheet of music. Only then can we all be on the same page and sort of public health would not be politicized. But and in that system, and we've seen that in a lot of countries that did do well, only if we have that type of system and that type of sort of communication, that sort of, uniform communication, only then will we be able to kind of really reduce the risk of morbidity or mortality.
I hear that, and I love that you started with that idea of the science is the science, and one of the things that means is it can it's updating, right? I mean,
yeah,
I talk to my students all the time, and they often ask, then what makes science science? And my kind of one way takeaway is science is falsifiable. Right. If we can't demonstrate counter evidence to the claims that we have, then we're not performing science anymore. But okay, let's take on some of the things that is happening right now, as your book is being published. So I hear that, but this past week, right, we have RFK asking a journal to redact a study that is a good study, right? I've looked at it myself. Again, that's not my area, but I can at least take a look at the methodology and say, yeah, this methodology holds up. So in that kind of system that you're talking about, there is an assumption that the individuals at that top level are taking public health as a scientific endeavor seriously. And so from my point of view as a political social scientist, it's hard for me to see that at this moment. When I see those kinds of, it seems to me, for example, that he would also suggest no matter what evidence there exists, I'm not sure I can falsify for him that autism is not linked in any meaningful way to vaccines. So how does that work into the context of what you're suggesting in the book to bring in some contemporary example, or the fact that, we are firing or attempting to fire CDC Director Monarez right now for similar kinds of reasons, for being, well, as again, Kennedy puts it, for not being in alignment, not with the science, but with the Trump administration, I guess, preconceived news of what the science has to be. What do we do with that?
Right. Well, thanks for that. It is a, I always like to, I'm an optimist, so I always like to look at glass half full.
I love it.
Having said
I don't need any more pessimism in my life, right? I need that optimism too.
Having said that, with the current secretary, I have challenges trying to find, the optimism there. And the reality is, It's because when it comes to him and his decisions, they were not. He was not put into that position in order to make the country a healthier place, despite certain sort of acronyms of MAHA and whatnot. He was there. He was sent to destroy the confidence in the sort of the scientific communities, because it is associated with academia, with education, everything that certain sort of members of the of our politic are deeply connected to, and that takes a lot deeper dive, and I can't really get into that in 5 minutes, but that is, yeah, I mean, so what RFK is doing is not rational. It is not supported by the science. It is the opposite of that. It is to destroy, they took away ACIP, they're, firing or, moving around or forcing people to sort of quit. Dr. Dimitri Daskalakis is a good friend of mine, and, I have great respect for him, and, him and Dr. Howery and Monarez, kind of collectively, we're sort of taken out. Who knows about the, Monarez? But I know, for example, Dr. Daskalakis is, very seasoned infectious disease doc. He's very committed. He's worked in the HIV space for many, many years, very committed to the communities. And he stayed, I can't believe actually how long he stayed. He was very resilient, and he was the head of NCARD, the National Center of Immunizations and Respiratory Disease. So he was really taking sort of a beating. And I was really, again, really amazed to see how resilient he was until he hit a breaking point. You just have to, you have to go. But, here's the optimism though. The optimism is the pendulum is going to swing back. The pendulum is going to swing back and order will be restored. Unfortunately, right now, we are probably going to see a lot more destruction in the next few years. And I think that people will, once those protections are receded further and it becomes more anemic, people will see the need for public health in the same way that let's say you decimated the budgets of fire service across the country, right? And certain cities then start burning and whatnot. People are like, oh yeah, I didn't realize how helpful or effective this was, right? Because when the system is working, people don't see it, right? It should be invisible to them. And so the more you take away those safeguards or those guardrails, people are going to be sicker. Increasingly, people are losing their access to Medicaid or Medicare. And so, safety nets are going to get further decimated. So both public health and healthcare are getting impacted at the same time. And, again, yes, all Americans, this is all Americans. This is not political. Blue and red, doesn't matter. The infectious disease, those little microbes, they don't care. Humans are humans. They don't know what your voting card looks like. And, they will, they are there, and the more that we question the science, the more that we connect it. With the obsession with autism and immunizations, it's not there. Full stop. It's not there. It's never been there. It started with a completely debunked study, the Wakefield study, with a sample size of 4 people, and it was not ever there. That paper was removed. That scientist was discredited. It's not there, and people continue to latch onto it, and it's weird and it's obsessive and it's just not factually based. And so the more that, and that's with science, if you don't start with science with like a predetermined outcome and then work backwards, right? Like that is not how it works. I mean, there is actually something called a case control study, but I'm going to put that aside. And
that's a longer podcast. That's going to be the one for my political method, or that's going to be my one for like our data analysis class here. We'll bring it back.
Right. So, but yes, you don't start with a predetermined outcome and then work backwards for the most part, right? Like you just don't, right? Like you have to, you take a sort of, you take an exposure, and then you look to see over time what the outcomes are. That's what sort of epidemiology is. You observe, and then of course if you're having more control, you randomized clinical trials, et cetera. But that is not science. So it's important to really socialize that and communicate that effectively. And, again, my 5-year-old, there is a natural inclination for young minds to understand the phenomena of the world. Right. And so my child who he knows Baba, his mom's Egyptian. So he knows Baba is a doctor, but he doesn't really understand the connection to science. And yet he just got his first science experiment, and he says, Baba, I want to do the science, tonight. And so there's that natural inquiry, which I love seeing. There's that inquisitiveness that the young brain wants to explore, and we should just allow that to thrive and not try to discredit science. Like, stop.
Well, I know that I've had you for a while, but as you talk about, you're an optimistic guy, and your book even kind of ends on that note. You finish. I love you italicize it. Even you're like, please hear what my actual intent for this book is, right? And I really loved that. So, what would be your last minute takeaway for listeners of the show? What's the final takeaway from your book in your words, please, not mine?
Yeah, I thanks for that. As a doctor, I was trained in medical neutrality. I worked in war zones, again, in certain areas where, there were, good guys, bad guys. We did not make that distinction, right? Because we were there as docs to just help all and to mitigate harm. For example, I was in, Israel and the Palestinian territories. I worked on the southern border of Israel. I saw the devastation there. I saw the devastation in Palestinian territories. So I was trained in that. And yes, of course, I have my personal opinions. We all do. That's what makes us human. But when it comes to my job, and when it comes to the communications around my job, which is this book is intended to sort of amplify, the point is that as a doctor, I want to make sure that everybody is protected. Right. And I don't care what people's opinions are about X or Y or Z, as long people are people. And for the most part, I find most people to be good and decent. And so we want to protect all people. And so we got to get away from again, trying to focus on the differences, and let's focus on the similarities, and let's focus on how we can get everybody protected, because I promise you that if we are able to do that, everybody wins.
Yeah. Well, thank you so much for being on the show, Dr. Evans.
Great conversation.
Well, we've been talking with Dr. Tyler Evans, and we've been talking about his book, Pandemics, Poverty, and Politics, Decoding the Social and Political Drivers of Pandemics from Plague to COVID-19. And it is out now. You'll also be able to get to it in the links in the show. If you've enjoyed this interview, I hope you'll consider becoming a supporter of the Politics Guys. It's what makes these kinds of interviews possible. To do that, head down to the show notes and click to become a supporter now, or head to politicsguys.com/support. So again, head to the show notes or to politicsguys.com/support to become a supporter of the Politics Guys and to make sure that interviews like this continue to happen. You can also be very helpful if you subscribe, rate, or review. Feedback to us about what you say here about Dr. Tyler. We'd love to hear that kind of feedback. You can also always reach us on email at mail@politicsguys.com. The executive producers of the Politics Guys are Wilmer Marino, Daniel Toe, Ryan Beasley, Don Oglesby, Derek Schmidt, Dakota Heath, Jason Chrysler, Dave Dean, Jeremy Larson, Brian Matza, and Jody Miller. We'll be back with a full episode this weekend, and I hope you'll join me.
This podcast is part of the Democracy Group.